Here we will discuss pharmacology of metoprolol, a comprehensive overview of mechanism, pharmacokinetics, indications, and clinical considerations. Introduction to metoprolol. Definition and classification. Metoprolol is a cardioselective beta-1 adrenergic receptor antagonist, second generation beta blocker with negligible effects on beta-2 receptors. It lacks intrinsic sympathomimetic activity and membrane stabilizing activity (MSA). Molecular weight 267.3 gram per mole exists as a racemic mixture with the S enantiomer being more active. Historical context: patented in 1970, approved in 1978, now generic on brands like Lopressor, Tartrat immediate release, Toprol XL 16 extended release, and Vitaloc. Therapeutic overview: primarily used for cardiovascular conditions by reducing sympathetic stimulation on the heart, lowering heart rate, contractility, and blood pressure. It improves oxygen supply demand balance in myocardium without significantly affecting lungs or vessels. Key features: lipophilic, allowing CNS penetration, selective for cardiac beta 1 receptors, making it safer for patients with asthma or diabetes compared to non-selective beta blockers like propranolol. Clinical relevance: reduces mortality in heart failure and post-myocardial infarction. Polymorphic metabolism via CYP26 leads to variable patient responses. Poor metabolizers have higher levels and risks. Mechanism of action: primary action competitively antagonizes beta 1 adrenergic receptors in the heart and kidneys, inhibiting catecholamine. Adrenaline, noradrenaline effects, thus blocks adenylyl cyclase activation, reducing cyclic AMP protein kinase A activity and L-type calcium channel function. Cardiac effects: negative chronotropic, less heart rate via reduced sinus node automaticity, and ionotropic, less contractility via decreased calcium influx. Prolongs AV node refractory period, slows conduction, and suppresses delayed after depolarizations. Renal and vascular effects: reduces renal secretion from juxtaglomerular cells, lowering angiotensin II and aldosterone. Chronic use decreases peripheral vascular resistance, initial reflex increases, resolves over time. Antiarrhythmic properties: class 2 antiarrhythmic, reduces pacemaker current, calcium currents, and adrenergic mediated potassium chloride currents, increases energy threshold for fibrillation and ischemic tissue. Selectivity and comparisons: beta 1 selective, minimal beta 2 blockade, reducing bronchospasm risk, no alpha blockade vasodilation or antioxidant effects, unlike carvedilol and bivolol. An overdose activity loss leading to non-selective blockade and potential sodium channel inhibition. Long-term effects: prevents myocardial remodeling, reduces apoptosis, oxidative stress, and sympathetic hyperactivity in heart failure. Pharmacokinetics: absorption well absorbed orally, low bioavailability 38 to 50% due to extensive fast hepatic metabolism. Peak plasma levels 1 to 3 hours, EMS 2 hours, and PMs 3 hours. Food may delay but not reduce absorption. Distribution: lipophilic, volume of distribution 4.2 to 10 liters per kilogram. Low plasma protein binding 10 to 15%. Crosses blood-brain barrier and placenta enters tissues readily. Metabolism: primarily hepatic via CYP26 or demethylation, polymorphic 3-10-fold, higher levels and poor metabolizers than CYP3A4. S enantiomer cleared slower than R. Active S has 35% higher levels than extensive metabolizers. Metabolites inactive 10 to 15% unchanged in urine excretion, hepatic elimination, biliary, fecal. Minimal renal 10% unchanged. Half-life is 3 to 7 hours. Extended in PMs to 7 to 8 hours up to 11 hours in some. Clearance 15 to 38 milliliter per minute per kilogram. Variability factor genetic CYP2D6 polymorphisms, PMs fivefold higher adverse risk. Age reduced clearance and elderly. Smoking induces metabolism. Pregnancy altered kinetics. Hepatic impairment. Dose adjust. Formulations immediate release start at 50 to 100 mg. Multiple daily doses extended release 16 at 25 to 200 mg once daily. And IV 1 mg over per ml for acute use. Next we have pharmacodynamics, cardiovascular effects, reduces heart rate, contractility, cardiac output, and myocardial oxygen demand, decreases BP via lower renin and chronic peripheral resistance fall, increases IV nodal refractoriness, prolongs PR interval, anti-ischemic effects, improves myocardial oxygenation by reducing demand more supply, prevents exercise-induced tachycardia, and heart failure improves LV ejection fraction, reduces LV size, attenuates remodeling 34% mortality reduction, metabolic effects balance hypoglycemia recognition less than non-selective, may increase triglycerides, decrease HDL, improves insulin sensitivity compared to non-selective beta blockers, other effects suppresses automaticity and ectopic beats, minimal bronchoconstriction due to beta-1 selectivity, reduces intraocular pressure, dose response AC50 for heart rate reduction, and the systolic BP25 and over ML effects more pronounced during sympathetic activation. Indications hypertension, essential hypertension initial 100 mg per day, titrate 200 to 400 mg. Monotherapy or with diuretics, all grades, prevalent combo, comorbid IHD, HF, angina pectoris, stable, unstable, prophylaxis reduces episodes, improves exercise tolerance, 100 to 400 mg per day, divided heart failure, chronic stable, and NYHA two-third EF less than 35% with ACI and ARB diuretics reduces mortality, hospitalization start low titrate 200 mg per day, post myocardial infarctions and prevention IV acute of stable, then oral reduces mortality and arrhythmias, rate control and atrial fibrillation, terminates heavy nodal retrant, tachycardia, supraventricular tachycardia is 25 to 50 mg IV, RPO, other hyperthyroidism, thyroid storm, adjunct for tachycardia 25 to 50 mg, and migraine prophylaxis 50 to 200 mg per day, and off-label emerging asymptomatic LV dysfunction, stress-triggered arrhythmias. Then we have contraindications, absolute bradycardia, heart rate less than 45 to 50 ppm, fast degree AV block, PR greater than equal to 0.24 second, sick sinus syndrome, cardiogenic shock, and decompensated HF, cardiovascular severe hypertension, systolic blood pressure less than 100 mmHg, severe peripheral vascular disease, Raynaud's aortic stenosis, and respiratory severe asthma, COPD, other pheochromocytoma, relative reactive airway disease, insulin dependent diabetes, warnings avoid abrupt withdrawal, and so on. Then we have adverse effects, common bradycardia, fatigue, dizziness, hypertension, CNS 5 to 10%, insomnia, nightmares, respiratory bronchospasm, metabolic mass, hypoglycemia, symptoms, triglyceride increase, less HDL, fluid retention, cardiovascular HF exacerbation, and at the end we have drug interactions, CYP2D6 inhibitors, quinidine, fluoxetine, increased levels, bradycardia risk, inducers, rifampin, phenobarbital, smoking, less levels, efficacy, absorption, less aluminum salts, cholestyramine, bioavailability, more cimetidine, hydralazine, and pharmacodynamic additive bradycardia, hypertension with calcium channel blocker, dopamine, diltiazem, and antiarrhythmics, digoxin, and other antihypertensives has blunted effect and SAIDs. Endomethacin via prostaglandin inhibition enhanced hypoglycemia risk. Insulin, oral antidiabetics, other digoxin level increase where hypertension with epinephrine, unopposed alpha mask clonidine withdrawal management monitor, HRPP adjust doses, avoid verapamil combo. Thank you. If you have any question, you can ask in the comment section.